FX Medicine is your gateway to news, resources and information on the safe, evidence-based approach to practicing complementary and integrative medicine. Visit fxmedicine.com.au to sign up for e-news and stay up to date with the latest research, podcasts and industry information. This is FX Medicine. I'm Andrew Whitfield Cook. Joining us in the studio today is Elizabeth Davigdor. Elizabeth has been a naturopath in continuous practice since qualifying 24 years ago. Today she combines clinical practice with lecturing at Endeavour College of Natural Health in Sydney. In her career spanning 18 years as a trainer at Blackmores and now Bioceuticals, she's responsible for education to healthcare practitioners on celluloid mineral therapy. She also runs a grassroots not-for-profit project in Ethiopia supporting the sustainability of traditional herbs and herbal medicine. Mineral therapy forms a core part of her clinical practice, and today we'll be discussing the application of treating children. Welcome to FX Medicine. Elizabeth, how are you?
Thank you, Andrew. Pleasure to be here.
Now, first of all, your career in research really interests me because it sprouted something from that. Can you take our listeners through what aspects of research in Ethiopia you did and what's happened since then?
Well, that research project was part of my master's degree with Southern Cross University. So with the support of my supervisor, Hans Wilmuth, I partnered with Addis Ababa University and the Ethiopian Institute of Biodiversity to find out what the story was with traditional medicine practices in Ethiopia, whether they're still in touch with their herbal medicine, whether it's at risk of loss, both the knowledge and the plants. So that took me off to Ethiopia, and I got together with a research group of herbalists and local householders in a rural town north of Addis Ababa, about 2 hours north of Addis Ababa. And we had great discussions, and what grew from that was this project, because once we'd finished the research, I asked them whether they were happy to leave it at that or whether they wanted to take it a little bit further and perhaps form a group and continue to support the dissemination of their knowledge. And they were very happy to do that. So now, several years down the track, that group is going very strong. The local council, because of their efforts with their household gardens, gave them a plot of municipal land, which is now a display garden. So there's something like 67 documented herbal species in that garden.
Yeah.
And we managed to give them some local training in permaculture to add to their skills, and also some business skills training. So, and now they're beekeeping. So they're well on their way. So I guess next steps is where I'm at now as to whether we try and replicate this project elsewhere. But there's good support for it. So this I might just add was funded by Blackmores and the Blackmore Foundation.
Yeah. So I've got to ask here about the intertwining of culture and medicine. When you look at traditional cultures, every single one, and I have not looked into the Inuit culture, but every single one that I've ever looked into on Earth is intrinsically linked to herbal, mainly medicine. And that's not just humans, that's animals. Like elephants will go into a pitch black cave to scrape with their tusks the side of the caves to access mineral salts because their diet is deficient. I mean, that's mineral therapy.
It certainly is.
And that's an animal thing. That's not a...
Right. So you're saying there's an instinct part of this as well as observation.
Well, instinctual or
something passed
whether it's
on.
a learned behaviour, but it's passed on as a something that works. Now, where I'm going here is the cultural aspect. It seems like where you've got a link with your culture, it's accepted by the government. Maybe there's also the fact that pharmaceutical medicines in these communities might be extraordinarily expensive.
There's another aspect
Yeah,
here,
okay.
and that is suspicion. So there is the oral tradition, and which is an oral evidence for hundreds and beyond, hundreds of years and beyond. And the householders are well used to using their herbs from an observational point of view with their children and so on, and with their families. They may not have access to a doctor. I believe that the government is trying to encourage more visits to doctors, but there is a lot of suspicion. So from a couple of studies that I've seen, that there is some effort to perhaps integrate the herbalist knowledge along with the pharmaceutical accessibility as well. So when there's little outreach clinics or the midwife going around visiting, that knowledge gets disseminated a little bit further too.
This was seen with the Ebola outbreak too, wasn't it? That this suspicion of modern medicine, and so people wouldn't bring out their sick relatives, and so therefore they were getting treated late and had a much higher death rate.
I believe so.
What about the acceptance, though, of the universities with supporting investigation into the natural medicines?
In Ethiopia, fantastic. There's some amazingly good work being done. What they're really trying to do are these ethnobotanical surveys everywhere, because these plants aren't simply documented. So following on from that comes the pharmacological investigation of the plants. But, for instance, with this little research project, we had a postgraduate student come along and did an ethnobotanical survey beyond the small one that we did of the area. We supported that student to do it. So that was the first ethnobotanical survey of that area, and they're just trying to, their aim is to document as much as possible. So they're at that stage of realising too that there are plants that may not be well documented. And then I imagine that there'll be the pharmacological thing that follows, of the investigation of medicinal properties and so on.
Does the further investigation from a pharmacological perspective put this herb at risk of being overused and being threatened from an ethnobotanical point of view? I guess the point in question or the case I'm making here is what happened with Prunus africana. It had to get put onto the CITES list because I think it was the French, showed its use in prostate cancer, and it became so popular that the land was basically raped of this, and it was threatened.
I think I came across that, someone telling me about these trees they were planting, but they were calling them blackwood trees, and they said for properties relating to prostate cancer. Look, yes, Andrew, it's a concern, and needs to probably be written into the template of any project such as this, that there's an awareness of how this is going to be used, whether there's going to be a huge emphasis on one particular species, and then that puts other species at risk. One thing that the group said, this was a female householder in the group, said that she was very concerned about, because I was also interested to know their awareness of the climate change or impact of the environment, and she and the herbalist both said there are herbs that used to be outside our back door that we now have to travel maybe for 1 or 2 days to go and find. They're not growing locally, and certainly I'm aware of the danger of promoting or trying to even make links to market for this group with particular herbs, whether they're going to suddenly focus on all these herbs at the expense of others. So yes, it's a delicate thing, and I think it needs to be written into any template, some kind of acknowledgement of this.
It's something, we all like the new best thing and something that's got evidence, but I think particularly with herbs, we need to be mindful of continuance of therapy and availability.
And incredibly respectful of the cultural boundaries in different countries. Yeah.
Very well done.
Yeah.
So, on to cell salt mineral therapy.
Another passion
of yours. So, tell us about some of the issues that you see around treating children. I guess we're going to be concentrating on treating children with cell salt mineral therapy.
I do find the mineral therapy as a modality incredibly useful for addressing childhood issues. I have a little bit of difficulty with the whole concept of treating a condition because it's very, very contextual. We've got a child comes in, and you might have two children come in with very similar diagnoses even, but you might be giving them very different minerals according to that presentation. And that's the the case history taking, the observational nature of understanding where that child is and why they got there, how they got there, when it started, all of those questions. So you can end up with a slightly different prescription.
So you're not treating the condition, you're
No.
treating the patient.
You're definitely treating the patient. The theme that comes through over and over again with using the mineral therapy is that it fits incredibly well with the naturopathic philosophy within that therapeutic order. You're at about level, say, 3, where you're tonifying weakened systems, I'd say, in terms of the therapeutic order. But for any naturopath, this is a very good first go-to when you want to be least interventionist but most effective.
So this eases, I've got to say, my concern with particularly childhood diseases where kids can go off very quick.
Yep.
And you can have something very, very serious happening and they will go off.
Yep.
And you have to act very quickly and responsibly in maintaining the health or getting them to appropriate care.
Yep.
What you're talking about is managing the patient regardless of what the medical diagnosis is.
Because that fits in with first do no harm. So when you have to apply your naturopathic medical principles first and foremost, and that is you have to have your training and education to recognise a situation, to know your diseases, to know your biochemistry, to know what the likelihood outcomes are. And of course, that applies to every single person that walks into your clinic.
Yep.
Children, as you say, can be quick responders and they can go downhill fast too.
Yep.
So that's always got to be first and foremost at the back of background of any situation. But most times it's not an emergency. And I always talk about these windows of opportunity. And that window of opportunity, the length of time depends on that child's current condition, whether they're in a reasonably or have been in a reasonably robust state of health too. So you're making all these sort of contextual clinical decisions all the time.
I think, for the totally vast majority of cases, you're relying on the alertness of the parent, and no mother is going to go, they're having problems breathing, I might take them to the naturopath. They'll go, heck, get me to a hospital quick.
Absolutely.
You don't get a second pair of lungs that easily.
Absolutely. You can be aware of the red flags. It's the red flags you need to be aware of. I really totally trust what a parent tells me. I believe the parent knows their child the best, and we have to listen to what the parent is saying, because they've been the observers for every minute, every hour and day of that child's life.
So what other things would you encourage practitioners to be alert for, to override or to add to that alertness of a parent? I guess where I'm going to in my head is, devastating disease where you've got peripheral shutdown, you've got flesh-eating disease and things like that. You've got meningococcal. So things like meningococcal, let's say, the glass test. This is not an early stage signal, but basically you put a glass against their skin and add some pressure. Under normal conditions, this will blanch the skin. It whitens. The blood gets pushed out of the capillaries. When you've got peripheral shutdown and you've got issues with infection with meningococcus, more specifically, it will not blanch. You still have that red stain going underneath the glass. You get them to the hospital and you alert them to that fact that you've done a glass test. So these sort of real urgent, emergent signs and signals, problems breathing, I wouldn't waste time. I'd be saying bypass, go directly to hospital, do not pass go.
It behoves us to know these things. That's incredibly important. I have to say that it would be incredibly rare to be at that late stage or mid to late stage of a disease coming into my clinic, but it's before that we've got to know these signs and take the cautious route and share that responsibility with a medical practitioner. And
now delving into cell salt mineral therapy, what is it?
That's a really huge question. My mind's going in a million directions as to where I actually start with that. All right, so it is a system of using minerals in particular forms. Maurice Blackmore devised this modality based on the precepts and concepts of Schussler. So Schussler, as I understand it, worked out that there were 12 minerals left in the human ash after cremation of the human body. And his idea from that was they must be incredibly important. So those 12 minerals Maurice Blackmore was looking at and thinking they were in a homeopathic form in Schussler's time, and they still are, but he felt that it was really important that there be a physiological dose of the mineral in the formula in order to address deficiency. And also recognising that in our time there is an increasing likelihood of deficiency because of either poor diet or environmental issues, and some issues that may not even have been around in previous times. So Maurice elected to remove the 12th salt, sodium chloride, because he felt that that was abundant in diets today and in his time, and was probably overused. So moving on from the 11 salts, one of the principles of this therapy is that they are in a particular form. And there we go into the little bit of the biochemistry where there are combinations of a cation and an anion. So we're talking the positive and the negative. And that's really a recognition of the body in its aim to try and maintain this neutral charge in its very homeodynamic way, trying to create a homeostasis all the time. And therein lies some of the safety issue as well. These minerals are very well accepted by the body. These minerals are found in a physiological form in the body. They are not designed to bypass the natural cellular gatekeeping mechanisms. And that's another safety issue with them too.
And when we're talking about safety issues, how does this differ from what we would ordinarily use in integrative medicine practice, using, let's say, if somebody had cramps, you'd give them magnesium, possibly some calcium, maybe a little bit of potassium. But physiologically, for kids, we'd be looking at, 100 milligrams elemental magnesium, and we're taught that we need the bioavailable form, the form that's more readily absorbed. That's our nuance to therapy. How does mineral therapy differ in this way?
There's a place for all of it. Okay, so in fact, you use the example of magnesium, and there may be cases where I would prescribe a different potency form of magnesium as well as the magnesium phosphate in the mineral therapy. And we can go into discussions of exactly where that is if you like, but that the one other aspect of the minerals is that we can give them very frequently at small doses, and that's abundantly so in acute cases where we want to give a more frequent dose, very low, gentle dose, but more frequently, rather than a massive great dose, say morning and evening, and you've got all that time in between for the body to sort out what it's going to do.
And you've got a greater propensity for side effects in that dose with laxative effect as well.
It's, again, got to be completely kept in context of that individual.
So let's go into the context of the individual. What sort of aspects do you take into account? Their constitution, how well or sick they are? But
that definitely relates to observing the child and taking certainly into context the history. So the child is going to be demonstrating in many cases the deficiency signs. So we're looking at those body signs to help put our picture together of what's going on there, but it has to be also taken into context of the history, the likelihood of perhaps a dietary impact on that deficiency, or whether the digestion is impacting on that deficiency. So it all has to get taken into account.
Would you take into account the child's constitution?
Yes, most definitely. Even from the point of view of whether it's a robust constitution or not. And there are definitely signs we look at which tell us that, but also listening to the parent. So when we're talking about the body signs, we're checking the tongue, we're looking at the fingernails, really good indicators of, for instance, calcium phosphate on both those scores.
Any other tools of assessment, even seemingly unconscious ones that you might employ in assessing that child?
That's a really good term, because I think there is a lot of that, and perhaps it might be what once was called medical intuition. Is in fact just it's speaking to something that's built on your knowledge. And observational experience. So I think from the moment you hear that person's voice or that child's voice, from the moment you see them in the waiting room, their bearing, how they're interacting, whether they're shy or not is part of what I'm looking at as well. But one of the discussions of calcium phosphate is the child that will suddenly be racing around the room and then suddenly be ducking behind mama's skirts and very shy when you address them. That would be what we'd call a qualifying symptom. So all of this is part of the picture, and it happens from the moment you see them or hear them.
The more I learn about cell salt mineral therapy, the more I am impressed by the need for learning about this system. That you can't just go, it's magnesium and phosphate. I've heard of magnesium and I've heard of phosphate. We'll just give them that. It really is a whole system of medicine based on symptom presentation, based on patient presentation, behaviour presentation. There's a whole host of things that go into it, not just a little bit of, quote unquote, a deficiency.
I think it doesn't take too long to learn. It takes a lifetime to master. And there's prescribing, and then there's refined prescribing. This is where the safety aspect comes in too, because you're not going to go badly wrong, but you can go much more right. And that just comes with the absolute practice of it.
So let's talk about what you get right and what you get right in. What sort of conditions do you treat?
Again, I have a bit of a difficulty with that word conditions. If we're talking children, we could talk about the condition called childhood or babyhood, because I have to. If it's the closest I come to any sort of formula prescribing, it would be the use of calcium phosphate and magnesium phosphate with children, because over and over and over again there's been a demonstrated need in so many of the children that walk into my clinic. The reason for that is, of course, they are growing like crazy, and all that calcium, that phosphate, that magnesium is pouring into the musculoskeletal system, often at the expense of the nervous system, because it's a priority thing. And so you could get a child that a mother comes in and says, I don't recognise my son anymore. They might be, say, 3.5. And he's turned from being a placid, happy child to becoming positively aggressive, not sleeping well, suddenly getting picky about food from a reasonably healthy diet. I don't know what's happened. Well, what's usually happened, barring all other indications, is growth. And their nervous system is just crying out for just a little bit more of these minerals to just do their work on the nervous system. And abundantly, primarily calcium phosphate. So often I'm giving it with magnesium phosphate because they're in that state at the time where tension has built up as well. It can have, I have to say it, I don't like to use the word, but parents have used the word almost miraculous effects, because it's so quick in filling that deficiency. I'll give you an example of a parent who came in with exactly that. She said, I don't know what to do. He will now only eat white food, which, as you can imagine, is
refined
food that doesn't need
devoid
to be.
of
Yes, that's right. Pretty well devoid of anything. And she said, and she was a diet-aware mother, and this was obviously distressing her, and the temperament had changed. And so I did give the calcium phosphate and magnesium phosphate, or asked the parent to administer that. She caught me in reception one day as I was sort of passing through and grabbed me by the arm and said, I want more of those little white pills. And while I don't really want to seem to be a purveyor of little white pills, I have to say that's not an uncommon response, just because it's that delightful response you get from someone where need has been filled or deficiency has been filled. And then they don't need to take it all the time. It's then certainly the emphasis can be making sure that it's there in the diet as number one principle, but it's a top up, and the parents become so proficient at working out when it's needed. And they will get the advice that, times have changed, just be mindful of this, starting school, when there's extra stress put on the system, this can be a first go-to.
How would you tease apart something that might be a behavioural change for, I have a slight issue with that word deficiency, because we're not talking about a mineral deficiency, we're talking about a need, a requirement for.
That can become a deficiency.
Yeah. So how would you tease apart the requirement for a certain mineral therapy combination, rather than some sort of issue that might be happening at school with interpersonal communication or bullying or even just phases of growth of life. A kid suddenly gets some behavioural lesson that makes them close in on themselves.
Because you do what you're supposed to do. You look at the terrain. You look at the environment. You look at, these are all the questions that you would be asking of the parent. Often that sort of thing is volunteered because the parent becomes very aware that this change has come about. They've just started school, or they've got a new teacher, or they've got some new friends have come onto the scene. And so that becomes part of it. But again, harking back to calcium phosphate and magnesium phosphate, it's actually a good case for supporting with that, because you're supporting how the nervous system is managing it. It's chewing it up pretty fast, and how it's managing it too. So it's a prop up and a support at that time as well, while those other that situation or that terrain is being looked at and addressed in as many ways as it can be.
You mentioned using, let's say, magnesium together. Highly bioavailable forms of magnesium combined with magnesium phosphate as an adjunctive therapy. What about other therapies that might be used in combination? Herbs, for instance, in
with
kids?
Children? Yes, I will if I have to. I mostly find I will always start with the minerals, again, if it's not an emergency. So I start with the minerals. We've got this window of opportunity, and then it's harking back to that therapeutic order again. Then you would go to the herbs, which are again still at that level of tonifying weakened systems, if you like. So we're still trying to just nourish the system to do what it needs to do. And so it's the least interventionist way. And then, if necessary, yes, you go to the herbs in a very managed way.
And I have to ask this question. I know we're getting off mineral therapy, but let's say from a cultural aspect, teas, herbal teas tended to be very well accepted by the older generations who might have a chamomile tea. But then we have potentially an issue, I don't think a great issue, but maybe some, culturally or even religious perspective issues with giving a child alcohol.
Absolutely.
So a herbal extract made with alcohol. Would you prefer, do you experience any issues, compliance, or indeed magical results from employing teas in kids?
I'm a huge fan of teas throughout. Pretty well every prescription will get, I have a little box for extra things people can do. And it may be a first go-to as well, because you're looking at, again, that person in the context of their lives.
Yep.
So all of that has to be taken into account. And it's the most wonderful thing of naturopathy that we have all these tools that we can use and choose from according to the context. So, yeah, I like using the teas enormously.
And then we have to address the aspect of compliance. Now, I can still remember my dad, and this was when I used to rubbish natural medicine, I got to say.
Did you?
Yeah, Oh. And I remember him giving me these little tablets. I also remember they're weird. They were a very strange taste to me, but I didn't dislike taking them.
Are we talking the mineral therapy here?
Yeah.
Because that sounds like potassium chloride and iron phosphate.
Right,
together.
okay.
Maybe you were getting a little fluey thing.
Maybe. But I do remember this feeling of them having benefit. And I know that sounds so weird and open to conjecture. I get it. And placebo, let's use the word. But I felt that, dare I use the term, they were doing me good.
You have brought up, I think, an incredibly important point, and it is something I've observed. I think children have an incredible intelligence about what is needed and what is meant to be rejected. And I have seen and had parents tell me that they have their own ideas about whether the child is going to accept something or not, and can be incredibly surprised that a child will almost ask for certain things at certain times. Now, back to the calcium phosphate, magnesium phosphate, no issues with that because it actually tastes okay. But I have had, they do know when they need something. I had a call from a parent who said, I just have to tell you that I am trying to grind the calcium phosphate, magnesium phosphate on my chopping board, and my son has climbed up and is licking it off the chopping board. And I think that there is a wisdom that we can respect there.
We all like to have evidence because it makes us feel nice and important and safe and validated. But I've had very good conversations with a man who I respect implicitly about things that are quite weird sometimes to me, and that is things like vitality, things for which we cannot prove. I am heartened and hearkened to a paper which was published in British Medical Journal by Smith and Pell, and it's a randomised controlled trial looking at parachute jumping, so for avoidance of gravitational injury, i.e. jumping out of a plane and avoiding injury. Who would like to go into the placebo group? So it was a tongue-in-cheek publication. It was published in BMJ. I think it was 2003. I'll put that up on the FX Medicine website for anybody who wants to read it. It's a cracker. But it alerts us to the issues of quote-unquote evidence-based medicine. Sometimes we cannot control for all things. Sometimes we cannot find the one thing. Where are we with evidence of mineral therapy?
In terms of clinical research data, we pretty well don't have much at all that I've looked at yet that I think fills the bill. So we're very, very clear on that. We do, of course, hark back to the hundreds of years of traditional observational evidence, which is valid in its own right. So yes, it would be lovely if we can find. The problem with these minerals and evidence is when I go looking, I very rarely find evidence on, say, potassium phosphate, whereas it'll just be on potassium, and you search and search and search through the studies trying to find, well, what form of it? That's where the big hole is. Yeah. And we really consider this cation-anion combination incredibly important. The anion is as important as that positive cation in terms of its benefit to the body or its need in the body. So as with all many naturopathic pursuits, we are always looking for that evidence. I think I'm detecting an element of certainty around science these days, and that bothers me a lot, because I sincerely believe that if you live your life in the realm of certainty, you're closing the door on possibility. And we don't know enough, even from all these wonderful studies which are building incredibly, so fantastic for our body of knowledge. We have to have this element of, great, that's another wonderful piece of the jigsaw puzzle. That can lead us a little bit further. So we need research on these areas, and most definitely.
I totally agree with you. I think it's really interesting that when you look at evidence-based medicine and you look at even accepted guidelines, which are fact.
Yes, that word
the
bothers
fact
me.
changes. The fact that paracetamol is the most useful first-line intervention for lower back pain is now being questioned.
Which is great. But we've always got to realise that we are going to be questioning everything, and that's a good thing.
So medical dogma is what we really need to fight against.
Yes.
Any caveats or safety issues that you might present? Now, I guess the only real one here, and even then, I wouldn't think it'd be such an issue as long as the child is eating, and that would be things like kidney disease. You can't get rid of a mineral, but even then, these are in such low dose that I'd feel very hard put that it's going to cause an issue as long as they're eating a reasonable diet.
It is, again, all part of the assessment, and it depends on the extent, and it depends on that very fine biochemical mix and timing.
And practitioner confidence?
Practitioner confidence must come from being able to say, I don't know, and being able to say, I'm going to go and look it up.
Or refer.
And definitely refer. That is a very confident and well-educated practitioner that will do that. And yes, there are caveats. It's that individual assessment. Potassium's another example. Well, potassium is a continuing example. A doctor would hear the word potassium and they'd be thinking something like slow K in terms of medication or prescription. Now, slow K is something like 600 milligrams of potassium. We're thinking about a tenth of that in a potassium chloride supplement in the mineral therapy. So if someone were on an ACE inhibitor, for instance, and I want to be mindful of what's going on there, potassium still may be a relevant prescription. You know, the amount is in one tablet would be about the equivalent of half a potato, something like that. So it also depends on whether they're on a potassium-restricted diet. It would be one of my benchmarks on that. So it has to be judged contextually.
What about things like pre-existing disorders, weird stuff like G6PD, the glucose 6?
Children particularly, yes.
Phosphate dehydrogenase.
Same answer, Andrew.
Yeah.
Same answer. It all has to be taken into account. There may be a need that has to be taken into account. So you've got to know your biochemistry a little bit in that respect.
Celiac disease?
Truly diagnosed celiac disease. Can I just add in there?
Ooh.
I have some issues there, or I'm discovering some issues there. Yes, deficiency relating to restricted diets too. So you've got to be aware of those possibilities.
Would you ever employ celloids in retrieving some of the gut-based cellular damage from from celiac disease?
Most certainly. All you're trying to do all the time is get that person's health up to their optimal. So again, you're going by body signs, deficiencies, what appears to be missing, and they often just match up to what you think should be appropriate for that condition. So for instance, if you feel like the digestion is compromised, you're starting to look at, well, what's the strength of the hydrochloric acid in the stomach? Do we need to perhaps be using potassium chloride to contribute some ingredients to that hydrochloric acid, get that fire of digestion going? Is there a systemic overacidity happening? Do we need to sort of support the body to manage that a little bit better with some sodium phosphate? You know, are these things indicated? And so often the confidence comes in that prescribing because it just matches up. All those diagnostic signs match up with the history.
What about epilepsy? And we've mentioned previously infections. Now, you know, very commonly, one of the most common reasons for a visit of a child with the parent to a naturopathic physician would be chronic infections, particularly, you know, the blocked nose, the glue ears, the bronchitic, asthmatic type symptomatology. Medically managed, but they're saying, I don't like this chronicity of it. Can we allay that? Can we alleviate that or abrogate those symptoms?
Yes.
What do you use? Have you ever seen any issues with adjunctive use with pharmaceuticals and celluloids?
Not so far in my clinical practice. I would not close the door on that possibility, simply because we're talking about individuals here. So we might have our knowledge and our biochemistry and all the rest of it, but then there's this extra little individual aspect that comes into it. We still got to go back to that wonderful question of when did it start? We've got to, especially with these chronic issues, and especially with things like glue ear and thick mucousy stuff. So when did it start leads you to why did it start? And so you're really going back to the beginning, to the original insult. So the original insult with children very commonly can be of course, there can be genetic components here, but then there's epigenetic components. Why did it switch on? Yes, why did it switch on? So you are pairing it back to that, and you're looking at what that original insult was. So you're while you're repairing the damage and the symptomatic stuff that you're seeing, it's like peeling the layers of the onion. You want that little core to pop up so that you know what you've got to address. And it may be there was an initial exposure to dairy that wasn't at an appropriate time for that child to manage, or the sort of dairy that we're dealing with now can be these little, you're looking at all these little, yes, it certainly is, to all these little trigger factors. And so you're removing what we call the disturbing factors, the obstacles to cure. Right. So that again is that same thing of getting that child's health up to their optimal and seeing what you're left with. And then seeing what you're left with in a chronic condition has come into play is how we can help to symptomatically manage that, continuing to strengthen up that robust nature of that child's original health, which is very likely been their inheritance, hopefully. And then also you're managing possibly with, because you're a bit further down the track than you'd like to be, with medications as well.
Where can practitioners get further education about this? This is obviously something they're going to have to study, regardless of what their prior learning or competencies are. This is a new branch. They're going to have to learn about this specifically.
They're teaching it in the colleges for naturopathic practitioners.
What about overseas?
Yes, they are. In fact, I'm not sure about today, Andrew, but I was teaching this mineral therapy in London and Brighton and Dublin about 7 or 8 years ago to the colleges there. In Europe, it's far more part of the understanding naturopathically to use the minerals. So for some people it's new. For some people it's really, really not new. It's been around for a very long time, since the 30s.
Right.
And when you meet a mineral therapy practitioner, they are often people who've used them for a very, very, very long time. I still use them in my practice because I see no reason to stop using them, because they're part of my clinical success with patients, and I don't want to walk away from them. So in terms of education, yes, the colleges are teaching it to practitioners, so there will be many, many more mineral therapy aware practitioners out there. There are courses that are available that you can go to, for instance, the mineral therapy, the Blackmore's professional mineral therapy online course, to get a very generic look at how these minerals are functioning and associated with learning the body signs associated with these minerals.
Can I ask if that involves the text by Alf Jacker?
We have 3 wonderful textbooks that I still go back to. I still can't believe that I look at that little brown book. I call it the Little Brown Book, which is Maurice Blackmore's original text. Mineral deficiencies in human cells, and I still find things in there. It must be just the timing. I've got something particular in my mind, and I still find something in there. You just mentioned the study about dropping out of a plane, and instantly I'm going back to Maurice's words, where he could not believe the results of giving potassium sulfate for fear of flying, and this person ended up a pilot or whatever. These wonderful sort of extra little tidbits are in there. Don't give potassium chloride to a married woman of fertile age, because she will for sure fall pregnant.
I think we need to work on that.
Maybe. Well, I do use potassium chloride in those situations. But joking aside, that book and the Alf Jacker book is a very good desk reference. Alf Jacker has had inestimable experience with the mineral therapy, and each person that has all these years of experience seems to bring something a little bit more to it from their observation.
I think his questioning mind shines through in the family with his daughter Felice.
Yes,
who's a brilliant researcher.
Lovely to listen to.
Professor Felice Jacker.
Yes. And then there's the Mineral Therapy Prescribers reference, which was put together by Paul Callanan and Belinda Fay. And that is actually a very useful mineral textbook, because it really goes into these minerals in some detail. So that's a very useful extra support.
Elizabeth Davigdor, thank you so much for enlightening us about your experience with cell salt mineral therapy, and also your fantastic work with the herbal medicines of Ethiopia, and preserving that sort of not just culture but system of medicine for those people to help them in their health. I really applaud you for that. Thank you so much for joining us on FX Medicine today.
Thank you very much, Andrew. It's been a pleasure to be here.
This is FX Medicine. I'm Andrew Whitfield Cook. Don't forget to visit fxmedicine.com.au for today's show notes, extra research and other resources.